myself as a family doctor here live, and recently I've become the course lead in this diabetes course from the University of Warwick, as Koki has told you. I just want to give you a little flavor of the course. It's a well-organized course. It does follow the IDF curriculum, that's the International Diabetes Federation. We do cover type 1 and type 2 diabetes. And recently we've had a recruitment round, and we have a lot of experienced tutors who are experienced in the practical aspect as well as the academic aspect. We do focus what's important in your region, and I'm going to come on to that in a little minute. We look at modern management, we look at individualizing care, important updates on studies and guidance. It is an online format, so it's flexible to work when you can. You can participate from your office or a place of your choice. And then we have weekly tutorials recorded for interaction and motivation. So it's a very well, it's been going now for about 5 years. It's well planned, it's well organized, and there's usually a face-to-face component taught as well. So this is from Paul Zimmet. It's looking at diabetes and its driver, the largest epidemic in human history. And this is a very dramatic editorial that he wrote. However, it does seem to be very true. Everywhere I go in the world teaching, I do come across this epidemic of diabetes. I will reflect with you that it's not quite as dramatic as in Japan, but certainly we teach a lot in the Middle East, and it really is an epidemic there. I had a great trip to Koki. I'll tell you, I had a great trip to Japan last year now for Hamani. This is Kyoto at night at cherry blossom time. It was a wonderful trip, and I just want to explore with you some aspects of diabetes in Japan, your guidelines, and then some aspects of primary healthcare systems and how they differ in Japan from what I practiced in. So there you are in Japan. You can see that you've got a prevalence of diabetes roughly equivalent to many of the European countries, sitting at about 7%. In Ireland here, it's between 4 and 5%. So, you know, slightly more than Ireland. Of course, you've got a big population, but you can see that you compare with, say, Poland, Netherlands, nothing like as high an incidence as other countries. But you're set to increase your prevalence. This is IDF data. You can see by, you know, the next few decades, your prevalence will certainly rise in Japan, and the number of people living with diabetes will rise. So it's like everywhere else in the world, it's becoming a more prevalent condition in Japan. Just to give you your data, then your population in Japan is 126 million. Your prevalence of diabetes is 7.7%. Your total cases of diabetes is 7 million. So that's quite a lot of people living with diabetes. And if you're working in primary care, then you'll certainly be coming across type 1 and type 2 diabetes in your practice. And you certainly need to be well. A diploma in diabetes would be a great asset to looking after those people living with diabetes. However, it's worth just reflecting that not everywhere in Japan has the same prevalence. So there and there have an increased prevalence. When I was in Tokyo, I tried to get an understanding from the students as to why that prevalence would vary across the country. We couldn't really quite decide, other than it's worth reflecting that type 2 diabetes, there are social determinants of health in terms of social deprivation, and rural areas also have a higher incidence of diabetes. And I don't know whether that's your experience or not, but there are regional differences in Japan, just as there are regional differences in England as well. So you can see in this case, the dark blue reflects England. And again, there's increased incidence, and this does patch on to areas of social deprivation and also patches on to where there's a high ethnic minority population as well in England. Well, I'm sure you've all seen this little diagram about the ascent of man and the evolution of obesity. What I would say that has all happened in a very short space of time, roughly 30 years or my working lifetime. Now, you don't see people like this walking in the street of Tokyo as much as you would say in New York or Chicago. But that has all happened in a short space of time. So really in Japan, body mass index hasn't gone up the way it has in American life. You do walk much more. You take 200 calories less than the average American. And of course, food prices are actually relatively much higher in Japan. So I want to come on to guidelines, particularly want to reflect on your Japanese guidelines. Excellent guidelines. All of you that are working in primary care should have access to these guidance. I think it's when you look at international guidance, it's very interesting to reflect that they're very similar throughout the world. So that we often refer to the standards of care. This is American Diabetes Association guidance. It's just been updated for 2020. In the UK, we've got Scottish guidance and then NICE guidance. These are all guidances that we follow. And I think you should be very proud of your Japanese guidance, which is very helpful to you in practice. Part of what guides, part of what helps us with guidance is this massive program of cardiovascular outcome trials which have been conducted over the last 10 years. They are reporting regularly. And of course, in our teaching, we teach you about these because they've had a massive impact on what we do. And some of them are being conducted in Japan, of course, as well. And this has led to this interesting algorithm now from the American Diabetic Association. It's too complex to talk about this morning, but it helps us to understand why we should use SGLT2s. There are 3 Japanese SGLT2s, why we should GLP-1s, why we should use metformin, why we should use other agents. And this is a full module, module 2. We talk you through the use of these agents, and we've just updated module 2 of our program to reflect on that. It all comes down to the person, though, living with diabetes, and you'll be very aware of this if you're looking after people with any chronic illness. You start at the problem, you develop a collaborative goal, you validate their plan, but remember, no decision about me without me is our motto when we come to teach the course. And that is a very important aspect of it, really, and that's one of our ethos of our course. We do draw lines in the sand. We teach a lot in the Middle East, where I use this metaphor a lot. We tell you about diagnosis, how to diagnose diabetes at 6.5% is the line in the stand, or 48 millimoles per millimole, depending on what you use. And we tell you and explain to you why that is, how you diagnose diabetes. Then there's the medications. I've referred to them and explain to you how you can use them. Plus injectables and insulin and GLP-1s. These are all things that we teach you during the course of the course and how to use them successfully and safely. Again, of course, we go into how each of these medicines work on the course. Again, I'm not going to do that this morning, but of course, it's very important to understand where and how the medicines work on people's systems. And then finally, we look at cardiovascular disease, of course, because that's very prevalent in people living with diabetes, and we have a full module devoted to cardiovascular disease in diabetes, and I'm currently teaching that with a group, and it's a very interesting subject. But of course, we deal with emergencies as well. So Cookie, I'm going to come back to you here. Suppose you saw that foot, Cookie, would it worry you?
Yes.
Yeah, I'm glad to hear that would worry you. Do you make any observations about the foot, Cookie?
Yes. Yeah. Yes. I saw this. So I have to consult specialist, foot specialist in
Yes,
this.
I mean, you'd want to contact a specialist, wouldn't you? I mean, this foot would worry you, wouldn't it? These calluses alone show that this is a foot that's not usual, isn't it? That the person isn't feeling the sole of their foot. And also, Cookie, I'm sure you'd agree this redness is worrying, possibly an infection. But this is very worrying here, isn't it? This black area, isn't it?
Yes.
I mean, this is a person living with diabetes. You could well come into your clinic this morning or tomorrow morning, Cookie. I mean, you would be very worried about this foot, wouldn't you?
Yes.
What do you think you would do?
Yes, gangrene. This black portion.
Yes,
Yes, it's
it's very
gangrene.
worrying, isn't it? It looks like gangrene, doesn't it? And I think, although we talk a lot on the course about diabetic emergencies, this also is a diabetic emergency, isn't it? This person's going to need hospital care today. They're going to need intravenous antibiotics, x-rays, and probably an MRI scan and urgent attention. So again, of course, during the course, we deal with emergency settings, and that's certainly an emergency there in front of you. But of course, we individualize diabetes care as well. We take into consideration aspects like hypoglycemia, disease duration, life expectancy, morbidities, various aspects. We balance up our treatments as well. And again, we'll be teaching you on that. So we're in a new era now. Cookie, isn't that right? Riwa.
Yes, that's right. Yes.
That's right. You've got a new emperor and a new era in Japan. And I think that's great. And I think I just want to reflect on the healthcare system in Japan. It is a different model than we have in the UK or Ireland. It's very much a hospital-based model, Cookie, isn't that right? And you don't have a gatekeeper system. So indeed, that person with the sore foot might have gone directly to hospital, mightn't they? Whereas in the UK or Ireland, they would almost certainly come to the GP first for attention. But I know that that's changing and that you're now beginning to develop board certified GPs and a GP healthcare system in Japan, which is more like the model we have in UK and Ireland. You don't spend as much on healthcare in Japan as they spend in the States or Canada, but you still spend a fair proportion of GDP. And I think your government is looking at that currently. And that's something that is also driving this board certified GP system. So what would integrated diabetes care look like? Well, you'd avoid any gaps or duplication, be smooth and quick referral. So as you say, that patient would be referred straight away. Your specialist could help in a primary care setting. You would avoid duplication of services. Some are best delivered in primary care. Some are best delivered by specialist care, and the best to achieve the objectives of the care of the patient. So just remember that sitting is the new smoking. So don't sit too long this evening. And of course, you're bad smokers in Japan. This is one of the things that surprised me. You have a much higher prevalence of smoking in Japan, which is why I've flagged that up. And it's an issue I know that you're addressing in Japan as well. So I had a great morning at the temple here when I was in Kyoto. It is a really magical place, and I just wish you all the best with the course. Happy to take any questions if you have any. Otherwise, I think Rebecca has something to tell you. Any questions for me at this stage? Are you enjoying the course, Koki?
Yes, I'm really enjoying.
Yeah, and pretty soon I hope you'll be going on to do a master's as well, will you, Koki?
Yes. Can I speak in Japanese?
Yeah.
Yeah. とりあえず、この質問とかありますかっていうことでしたけど、なんかそのプログラムのことも多分少しもうここで聞いてしまってもいいのかと思うんですが、皆さんの方から何か、どんな感じでやっていくのとか、いろいろ質問あると思うんですが、はい。吉田先生とかでもいいですけど。
はい、わかりました。Okay, Professor Corin.
Yes, hello, good morning. Hi.
Hi, good morning. I'm the old friend of Koki Kato,
Yes.
I'm the director of primary care family medicine program in Kyushu. I'm Shin Yoshida. Nice to meet you.
Yes, nice to meet you as well. Hi.
Thank you very much. Hi. So I come here for my junior family doctor who are keen to be specialized for diabetic care. Yeah.
Yes.
But his career, so he's only maybe might be chance to be specialized for this area is getting the certification of Japanese diabetic specialist. Yeah. So I'm gonna ask for the difference between your course and some local specialist course of diabetes. Do you have any characteristic for this course as a maybe primary care kind of, yeah.
Yeah, I agree with you that we do have a primary care approach to the course. It is a very scientific course. It's taught against the International Diabetes Federation curriculum. So the course isn't conducted at random. It follows through 6 modules. And I know Rebecca is going to explain this course to you. I like to think we have a primary care ethos on the course. So all of us are family doctors or diabetes specialist nurse. We do teach from a family doctor perspective, but we do also teach the science of diabetes as well very clearly. And so therefore, I think from yourself in Japan, it is a very internationally recognized course. After all, we do teach all over the world, and it's a very well respected international qualification. Okay. But that we do have a primary care perspective on it. That's true. Does that help you?
Yeah, of course. So additionally, so could you show me some example of the graduate of your course? After the graduation of this course, some students still collaborate with local collaboration with the DM specialist. So I mean, so sometimes for the primary care doctor, some of the treatment options don't get used to primary care doctor, such as a GLP injection kind of. At that time, so I sometimes consult with a local specialist. So do you have some good collaboration example?
Yes, I mean, we've got very clear examples of that in the Middle East, where a lot of our graduates now, because we've been teaching in the Middle East for 3 or 4 years, and a lot of our graduates have gone on to collaborate with local governments in the Middle East to try and extend the reach of primary care doctors. What you're saying about GLP-1s we hear all the time, because in the Middle East, for example, they're particularly expensive there. And so therefore we hear that their use is restricted there. It's not so in the UK and Ireland, where they're used much more regularly by family doctors. Whereas in the Middle East, insulin is much more commonly used. So we do recognize all that, and we reflect our teaching on that. And a lot of our teaching is very practically based. But I do believe this is a very well respected qualification. Rebecca is going to tell you about that. But also, we also feel it's a very practical course that would help you with your everyday work, help you look after your patients living with diabetes, but also help you communicate with secondary care consultants as well.
Okay, thank you.
Does that help you?
Yeah, of course. Yeah, thank you. Wonderful.
Now, have we got any other questions here? Or Rebecca, shall I hand over to you?
Thanks, Colin. Yeah, I will just start my presentation now, guys. So I am just going to walk you through what to expect on the program and the programmatic overview. Can you see my screen? Yes?
Yes.
So first of all, I'll just explain who IHEED are. Who are we? We're an Irish online medical education organisation. So we specialise in bringing, particularly to primary care doctors and clinicians, as Dr. Colin Kenny has said there, bringing online medical education and blended learning globally across the world to primary care. So we have high-level agreements with ministries of health and government globally, particularly in the Middle East, as Dr. Kim said, in Saudi Arabia, Qatar, and the UAE, now more recently in Malaysia, Japan, and of course the United Kingdom and Ireland. We have, as I said, medical education specialists with particular interest in primary care. We have over 300,000 course completions on our learning management system, and 30,000 doctors and clinicians registered on our system in an IHEED program. So we are the online program manager for the University of Warwick for this postgraduate diploma and Masters in Diabetes Care. Just to tell you a little bit about the University of Warwick, they are number 9 in the United Kingdom, and they're always in the top 10 in the US rankings, world rankings, 54th in the world ranking. They have educated over 14,000 diabetes graduates. So they have a very special nuance or interest or expertise in diabetes education. They're a member of the Russell Group, which is the top 30 most active research university in the United Kingdom. So they're very highly ranked and very interested in diabetes research in particular, but the Warwick Medical School has an exemplary reputation. And the students who study on this program get the exact same qualification as the students who fly to the University of Warwick and sit a face-to-face qualification. So nowhere on your certificate does it say that online or distance or blended. It is the exact same qualification, the exact same prestige as studying face-to-face. So the postgraduate diploma to commence with is a 12-month part-time program. And if you want to go on to the master's stage of the program, it is an additional months. So in total, to get your master's, 20 months, or if you want to exit with postgraduate diploma, it is 12 months. As Dr. Kenny said, it is designed entirely around the International Diabetes Federation. We have very close links with our academics, with full international accreditation from the university, as I said, and it's designed and delivered by world-leading diabetes experts locally and internationally. What I am very proud of in terms of professors and academics on our program is they're not always academically focused only. They are also practicing general practitioners and family medicine specialists working on a day-to-day basis with diabetic patients. So in terms of the state of the art and the most recent interventions, they are at the cold face of diabetic care. So they know exactly what it's like, just like you, to treat a patient on a day-to-day basis. So they're not just in an academic setting. And the platform itself is extremely advanced. I've been in the education world for over 20 years. And I have never seen a learning management system with this level of immersion and this level of, I suppose, dedication to 3D videos, to competency-based assessment, hot topics, case-based. It's very discursive, and it gets across very complex theories in a very digestible and easy to understand format. So it really is a wonderful experience in terms of being engaging and interactive, and you learn with your peers in a discursive manner. So just in terms of some of our faculty, this is actually just a taste of our faculty, because we have a very considerable faculty all over the world now, which we're very proud of. So Dr. Kenny is our program director, and he's the Royal College of General Practitioners examiner and a past chair of the Primary Care Diabetes Society. We also have Dr. Martin Hadley Brown, who is a clinical tutor in the University of Cambridge and former chair of the UK Primary Care Diabetes Society and clinical diabetes lead for the Royal College of General Practitioners. Dr. Stephen Lawrence is within the University of Warwick and is our program liaison within the university. And he's a senior diabetes lecturer in the University of Warwick and an advisor for diabetes in the Royal College of General Practitioners. Dr. Mohammed Farghali is he's considered a key opinion leader in diabetes management in the UAE and indeed throughout the Middle East and the GCC, the Gulf Cooperation. And finally, we have Professor Dr. Katie Reid from the University of Manchester, and she is a world-leading expert on I suppose, patient motivation and clinical change and patient change within a clinical setting. So behavioral change. So she very much teaches on module 3 on the program. So, sorry guys. Next, so what does the program mean for you? We have, even though it's an online or distance program, you are never ever left alone to study in an isolated environment. And I think that's one of the major advantages of this program. You really are handheld and looked after, and you are known by name. You are not just a number, and the tutors get to know you very well. And as a result of that, we have very small groups. We have 20, maximum 25 in each tutor group. So you get to know your clinician peers from across the world in your group very, very well. So once per week, you will you have 6 weeks modules, should I say first, a 6x6 week, and then there's a break in between each module. You have a personal commitment of 10 to 15 hours per week. Now that is considerable, very much for very, very busy doctors and clinicians. So we understand it is not to be taken lightly, and it is a huge commitment from our students. But other programs, similar programs globally around the world, usually take 2 to 3 years to complete this program. And you will complete it with ourselves in 12 months for the postgraduate diploma and 20 months for the MSc. So as a result of that, it is very intensive, and we want to be very honest about that. But just to, I suppose, give you reassurance, you get an awful lot of individual support on the program. And the program, because of learning, we have extremely advanced analytics. So we can see how many page views a student has had, how many times they've participated on the tutorials, quizzes, essentially all of their interactions with the platform. We have the analytics to see exactly what each student is doing. And if you fall below a mean average of participation on the program, we have a group of mentors here in the Dublin office that will reach out to the student and see if you are okay, if you need any assistance, and really help you to make sure that you don't fall behind. And as a result of that, we have lower than average attrition or fallout rates on the program. So we're very proud of the support we get. So just to walk you through the curriculum or the program content, we commenced the program with Module 1, which is the core principles, essentially epidemiology, diagnosis and screening, and pre-diabetes and classifications. Next is a very weighty module. It is our treatments module. So this is all our medicinal interventions and pharmacy. So it's diabetes management, your chronic illness model. And that's one thing the doctors on the program tell us, is that not only have they learned about diabetes care within the community, but they've also picked up very good skills around chronic disease management for all chronic diseases. So if it's cardiovascular, if it's COPD, they can easily take the learnings they have learned from this program and put them across all communicable diseases or non-communicable diseases. So that's very important learnings. We also look in this module all around the medical or medicinal interventions, so glucose lowering medicines, your insulin, your pump therapy, continuous monitoring, and then extreme circumstances, of course, we will look at weight loss surgery. And we also look at the latest clinical trials and new medicines and new treatments, and what is first and second line and third line treatments. The next one is the module that the doctors really enjoy. They say that it really helps their interactions with the patients in terms of behavioral change in a medicinal setting. So it essentially, as Dr. Kenny said, no decision about me without me is our motto on the program. So it's all about teaching the patients to care for themselves. As a doctor, you may see a diabetes patient maybe 3 to 4 hours maximum per annum, and that is a good interaction level with a patient. But they have to live with themselves for every other hour of the year. So it is very important that they understand their own disease and how that they can manage their own illness to their best of their ability. So it's all about educating the patient to look after themselves. So that's module 3. Module 4 then is complications, microvascular complications. So you'll be looking at your retinopathy, your renal, you'll be looking at how to interpret retinopathy scans and your foot examinations. Our next module, as Dr. Kenny is now teaching on at the moment, is your macrovascular complications. So of course CVD is very prevalent in patients living with diabetes. So we would look at that in huge detail in module 5, heart disease, stroke, etc., and how to manage that in primary, secondary care and interventions and prevention. And finally, we finish off with special situations. This can vary, this module, depending on the region of the world that you are in. But examples of the special situations would, of course, be pregnancy and diabetes, gestational diabetes, religious like Ramadan and Hajj, fasting for religious purpose for a patient living with diabetes, and sports travel, and then of course mental health as well, and diabetes management with older people. So they're the special situations in our final module in the postgraduate diploma. If you are still happy and you are enjoying the program, many of our students will progress onto the master's level of the program. In the master's, we essentially have 2 modules. We have the research methodologies module, where the student will understand critical appraisal. They will do their quantitative and qualitative analysis and essentially prepare for their professional project. And then within the professional project, we are very excited that the master's is not just a thesis. It's not just one big essay that many universities do worldwide. We are a very practical program, and what we expect of the students, in my opinion, is excellent, because you will be doing a poster presentation, and you will also be doing, you'll be creating a journal submission for either a local or globally recognized medical journal. So our output from the master's is that you will be a published doctor with a specialism in diabetes care in primary care. And that is very, very important, because it helps your CV and your personal profile, but it also gives back to the diabetes research community globally. And that raises the profile of your own individual profile, but also raises the profile of our program globally. So that's what to expect for the master's. So how does the program work? We do face-to-face workshops throughout the world. We have done them in Japan in the past. And just to be very clear with all of you, that we do need a viable number of students in Japan to be able to run the face-to-face workshop in Japan. So we need really a viable number of 15 doctors to be able to run the face-to-face workshop. But we do them all over the world. We do them in the Middle East, we will do them in India, Australia, Malaysia, and of course in the United Kingdom, in the University of Warwick, and in Ireland as well. So the workshops will teach you everything that's better to be taught in a face-to-face setting. So things that are very practical. So how to interpret retinopathy scans, how to conduct a very good foot examination, look at pump therapy, all of the things that would be good to do in a face-to-face setting. We also, in the clinical workshops, I think one of the main advantages is to get to meet all your class in person, in face, and not just on a video screen. So we start the program with the face-to-face sessions because it is a really nice way to get to meet every one of your students in your class and get to know each other very well at the commencement of the program. After the workshop, we then go into the first module and every module thereafter, and we have a weekly discussion forum online. So your tutor will give out a program topic which covers the learning outcomes for that week, and you then have that discussion topic on the forum, and you're asked to interact on that forum. So it's very much case oriented. So you'll have a patient, could be a complex case with comorbidities in older life, and you're asked to discuss how you would treat that patient, and you'll be covering a particular topic. And so you would interact on the discussion forum with the tutor moderated, but all of your peers will interact and say how they would treat this patient. And it culminates at the end of the week with an online live tutorial, just like we're having now. It's in real time with your tutor and the rest of your class. So you will discuss the topic for the week with the rest of your class. And it's really, I think the best part of that is to find out how other doctors around the world would treat that patient and their medicinal interventions, and learning best practice from the tutor and from your peers around the world. And we also have continuous assessments. So at the end of each module, we would expect an essay. It's a 2,000-word essay at the end of each of the 6 modules. And at the end of each semester, so a semester is 3 modules, we would have an online examination. So that's done in the comfort of your own home. It's online exam conducted by an American company called Examity, which is an online proctoring system. And it's predominantly MCQ questions on the exam. So next, we just give you a taste of what the platform is like. It's a very unique online experience. It's very case oriented. So we discuss patient-based case scenarios. That one is actually from the Middle East. So you'd look at the HbA1c levels, creatinine, the blood pressure, and you discuss that person and how to deal with them on a case-by-case basis. We have expert videos from key opinion leaders globally around the world. And as I said, we have the online live tutorials, just exactly what we're doing now on the Zoom platform, where you interact with your peers every single week. In terms of administration and support, we have your program leader, Dr. Colin Kenny is our director, and then the program leader in the University of Warwick is Stephen Lawrence. And we have the tutor network for every single module. You will have your tutor. And then here in Dublin, in Ireland, we have our mentors, and they will be the ones that you will get to know very, very well. If you have any problems whatsoever, you reach out to them and they assist you on the program. And course management team and technical support. So the student experience, we have 280 students from over 25 countries, so we're an extremely global program. We have an 88% student engagement and participation on the program, so we're very, very proud of those participation rates and interaction with the system online. We conduct a survey or questionnaire with our students at the end of each semester. So we have 100% positive on program support and organisation, and net promoter score is extremely high, and a 92% pass rate to date on the program. Now, that is not because we are lenient, and it is not because it is an easy program to study. It is simply because we are teaching professional doctors and they are very dedicated. So I think that the pass rate is a testament to your own dedication to the program. In terms of the program impact, I think this is a very, very important slide, as it shows confidence levels both before and after doing the program. So the purple or blue line is the confidence levels of the doctors before they started the program. And the green line is their confidence levels after they finished the program. So in terms of prescribing for cardiovascular prevention, GLP-1 agonist initiation, helping someone to overcome obesity and type 2, initiating and adjusting insulin levels, recognizing emotional distress and mental health challenges in a young adult with type 1 diabetes, recognizing and diagnosing type 1 diabetes in a child, and knowing when to refer to secondary care. And I think that's really important for primary care clinicians, that the level of referrals really declines, therefore putting less pressure on secondary care, which is very, very important in the United Kingdom and Ireland, but globally, in terms of just taking the pressure off secondary care and enhancing the effectiveness of primary care intervention. So just to synopsize what the learning environment is like, we've synchronous online tutorials, we've interactive case studies, tutor moderated discussion forums, innovative clinical assessments, we've advanced analytics to support the students, we've measurement of competency. So for example, we won't be just doing essays, you won't be just doing quizzes or your end of semester exams. We also ask you to upload videos of competency. So we would ask you to upload a video of yourself conducting a motivational interview with a student in module 3. Or in module 4, we would ask you to upload a video conducting a foot examination on a patient. We would give you a rubric of best practice in that circumstance, and then we would mark your video out of the rubric of best practice. So that's a really good way of doing a competency-based assessment. We've 3D medical animations and imagery and access to full online libraries, an exemplary online library in terms of access to formularies, the BMJ, and world-leading medical journals that we will reference all the time and hyperlink to throughout the program, and interactive quizzes and hot topics. So the entry requirements, we need to see proficiency of English language. It does not necessarily need to be the IELTS or TOEFL examination. If you do not have a recent IELTS or TOEFL examination, we can also do a 5-minute interview with you on our platform, and we give that into the University of Warwick as evidence of your English proficiency. And they will accept that as acceptable evidence of your English capability. And you need to be fully employed in a medical practice, so you need a reference letter to say that you're fully employed. You need your degree or university transcript translated into English. You need a personal statement of 500 words, just outlining why you want to do the program and what is your motivations for doing the program. As I said, you need an academic or employer reference letter and then a photo ID. The photo ID is not a selfie, it is a government ID, be it your driver's license or your passport. And there are limited places available, so early submission of applications is very, very important. Sorry, that says October, it should say March start date. So the full fee for the program, I quote in euros. I have given the Japanese yen conversion rate as of today, but that may vary depending on when you pay. So please note that we do quote and charge in euro, and the yen price is indicative as of today. So that's the full price of the postgraduate diploma. We do give a discount for the Japan Primary Care Association members. So that brings down the price, and that is it in yen and in euro. But there is an additional fee after the postgraduate diploma if you wanted to go on to the Master of Science element of the program, which is an additional €4,500. In order to secure your place on the program, you do have to give a deposit, and that makes sure that your place is absolutely secured. But we do provide flexible payment options, so you can pay by semester or you can pay by monthly subscription. And I can give you a detailed overview of your monthly subscription fees in an email after this session, and I'm happy to do so. And so the summary, so it's a 12-month postgraduate diploma. It's an 8-month MSc on top of that, so 20 months in total to get your master's. It's awarded from a top 10 United Kingdom university with local and international recognition. And it's part-time, but we do expect 10 to 15 hours of dedication per week. There are limited places, and it's a very innovative program. And the doctors on the program, I think the top advantage they say is global exposure. And actually, of course, learning the curriculum, but also learning from your other fellow doctors throughout the world. And they really, really enjoy the program. So that's it. So have you any other questions for me? No?
Okay.
I'll end the
Hi.
Hi.
Hi, Shin.
Hi, hi, Rebecca Patterson. Thank you very much for your instruction. So, my question is about dedicating time per week. So you said it's 10 or 15 hours a week. So, how is the ordinary securing time for your students, such as maybe I guess many of them work on daytime. So does they do the night study overnight or dedicating their holiday?
Yes. Now, I will say that we must say 10 to 15 hours. Sometimes you will have less, but coming up to the exams and coming up to an essay submission, you will definitely have that. So it will vary. And I think that's the nice thing about the program, that you can study at your own time in your own pace. And the only thing that you must attend is the 1-hour tutorial every week. And we do that at time convenient to doctors locally in Japan and Malaysia. So your group will decide what time is most convenient per week. So it's usually on a Thursday and Friday after your clinic. So that 1 hour is compulsory, really. And the rest is at your own time, whenever you are able and whenever you are free to be able to study. And if it's an emergency, if you can't make that tutorial, we do record everything. And you can download it afterwards and review it in your own time as well. So we don't want to underestimate the level of dedication you must show to the program, but we don't want to scare you either.
Okay, thank you very much.
So, Shin, that must be the question that's asked most often, the time that you need to devote to it. It does vary a lot for individuals, but I think to get the best out of the course, you really need to be doing quite a bit of course reading around each of the modules, both, you know, to be competent and proficient in the diploma, but also to, you know, complete the various quizzes and things that are required. So it very much depends on how you are as a student, but to get the best out of it, I do think you need to devote some time to it. Probably best broken up into chunks rather than sitting down for long periods of time. That's what has been most successful for people, is chunking the study up. And again, the way we teach the diploma seems to suit that very well.
Okay, so thank you very much. So I want to have this question for Koki Kato in Japanese. Is that all right? Too?
Yeah, in Japanese.
Yeah, of course, because this is a very you know interesting question for everyone. Yeah.
Yes. その何時間ぐらいかけるかって今10から15時間って言われてましたけど、かなり人によってばらつきがあるよっていうことで、10から15っていうからそんなにびっくりしないでいいですよっていうようなコメントが今出てました。で、ドクターコリンからは、加えて、そのプロフェッショナルとして、そこに精通していくにあたっては、文献読んだりとかいろいろあるので、時間はかかる部分はあるけれども、それでもかなり連鎖が大きいよという話が出てました。 で、実際僕はその週のラーニングコンテンツをオンラインでこう見てって学習するのに、数時間ぐらい1週間にですよ、3時間4時間とかかける時があると思います。もっと早く終わる週もありますし、3時間から4時間ぐらいかかって、それと別にチュートリアルは1時間ぐらいあるんですよ。なので、それが大体定期的にかかる時間で、それ以外はエッセイにどれぐらい時間かけるかっていうところだと思うので、そこは書くの得意な人は短く済むでしょうし、苦手な人はもうちょっとかかるかもなっていう風な感触かなと思います。
あれですよね、なんか管理者としては金曜日の午後を開けてあげればいいんですかね。
一応、金曜日の今8時からとかやってますね。
はい。ありがとうございます。
Yes, I was talking my experience.
Yes, of course. And thanks so much, Cookie. That's really helpful. And I'm pleased that you're getting on well. And would love you to continue on to do the masters as well. I think it would help your professional development a lot. Are you still trying to keep fit and keep active? Keep your steps up?
Yes.
Good man.
Yeah. 他は皆さん何かないですか？あれだったら日本語でも多分大丈夫と思いますが。
Okay, guys, if there's any more questions, if not, thank you so much. We will follow up this webinar with an email and follow up with you individually to see if you would like to get on the program. We have also recorded this webinar, so we can send out a recording to you if you want to review it again at your own pace. Okay, so thank you so much for your time, and please keep in touch if you have any other questions. We'd be delighted. And Asana here, who is on the webinar as well, she is our local liaison in Japan if you have any other questions for her also. Okay.
Thank you so